Welcome to this brief presentation on the second edition of the Millon Adolescent Clinical Inventory, referred to as MACI-II. The MACI-II will be published in early 2020, and we would like to share some of the updated features of the assessment. I am your host, Dr. Anne-Marie Kimbell. The MACI-II is a self-report instrument designed to assess personality characteristics and clinical syndromes in adolescents aged 13 through 18 years who are undergoing psychological assessment and/or treatment. It consists of 160 true-false items. The upper end of the age range was reduced from 19 years on the MACI to 18 years on the MACI-II. The authors are Dr. Theodore Millon with Drs. Tringone, Grossman, and Carey Millon. The MACI-II has evolved from its predecessors, the Millon Adolescent Inventory, developed in 1974 and forerunner to the Millon Adolescent Personality Inventory, published in 1982, and the Millon Adolescent Clinical Inventory, published in 1993. The first edition of the MACI was updated in 2006 to include the Grossman Facet Scales, and that evolution continues with the MACI-II in a number of significant ways. The MACI-II consists of 24 clinical scales that have been constructed to assess an adolescent's developing personality type, clinical symptoms, and subjective concerns. The scales are presented in three sections: personality pattern scales that assess more stable patterns, expressed concerns scales that assess distress in self-oriented and interpersonally based areas, and clinical syndrome scales that assess more acute and transient clinical syndromes. The MACI-II was developed for use with adolescents who are involved in mental health assessment and/or treatment. It is not a general personality instrument to be used with non-clinical populations. It is intended to identify and clarify clinical concerns. Use of the test should be limited to adolescents who fit the normative profile. For example, the MACI-II is not appropriate for adults or children younger than 13 years or for non-clinical populations. The MACI-II includes new and updated test items to increase clarity, simplicity, and clinical relevance. In addition, the item overlap on MACI-II is reduced across scales to increase scale independence and improve discriminant validity. The MACI-II includes 9 scales that assess acute and transient clinical syndromes. The clinical syndromes, such as anxious feelings and depressive affect, are usually the initial focus of treatment. They stand out as relatively dramatic and notable behavior, thought, and/or feeling patterns that call attention to the person as one who requires professional help. Compared to the MACI, there are several changes to the clinical syndrome scales for the MACI-II. The name for scale AA was changed from eating dysfunctions on MACI to binge eating patterns on MACI-II. Items assessing anorexia symptoms were removed, and the scale is now focused on binge and overeating and bulimic symptoms. 3 new clinical syndrome scales were added to the MACI-II to identify important conditions that reflect current clinical presentations among adolescents. The new scales are disruptive mood dysregulation, post-traumatic stress, and reality distortions. The impulsive propensity scale on the MACI was dropped from the MACI-II. Impulsive tendencies are captured by several other scales on the MACI-II. The MACI-II includes 4 scales that assess expressed concerns, feelings and attitudes about issues that tend to concern troubled adolescents. The scales are identity diffusion, self-devaluation, peer insecurity, and family discord. In addition to these 4 scales, the MACI included 4 additional scales that assessed expressed concerns. The scales body disapproval, sexual discomfort, social insensitivity, and childhood abuse were dropped for MACI-II. 11 of the 24 clinical scales assess stable and enduring personality patterns. In Millon's theory, the personality patterns are key because they represent our overall capacity to perceive and to cope with our psychosocial world. The MACI-II personality pattern scales correspond to many of the personality disorders recognized by the DSM-5. However, to acknowledge the dimensional nature of these constructs and the instability of personality traits among adolescents during this developmental stage, the MACI-II personality pattern scale names are less severe, and elevation on the scales does not indicate that personality disorders are present per se. The personality pattern scales on the MACI-II reflect advances and refinements in the test's underlying personality theory. New items were written for each scale, and the borderline tendency scale now has prototype items designed to assess the corresponding construct specifically. Previously, the borderline tendency scale was made up of prototype items from other scales. The doleful scale on the MACI was removed for the MACI-II because adolescents often co-elevated on this scale and on the Depressive Affect Clinical Syndrome scale. This made it difficult to differentiate between a long-term personality-based construct and a common depressive clinical condition. In addition, the name of the scale 8A was changed from oppositional on the MACI to discontented on the MACI-II. The name of the scale 8B was changed from self-demeaning on the MACI to aggrieved on the MACI-II. The MACI-II has 12 noteworthy response categories, including vengefully prone and bipolar spectrum. The critical items include those that inquire about vengefulness, suicidal thoughts, non-suicidal self-injury, traumatic experiences, lapses in reality testing, despondency, despair, bipolar symptoms, explosive anger, impulse control problems, instrumental anger, substance abuse, and eating concerns. The MACI-II includes 3 indices that assess validity. The invalidity index was reliability on the MACI. The items ask directly if the adolescent is responding truthfully to the items. The MACI included 3 modifying indices, disclosure, desirability, and debasement, which generated scale adjustments according to an examinee's response style. These have been replaced by 2 new response validity indicators on the MACI, response negativity and inconsistency. The response validity indicators detect non-content-based responding, inconsistency, and under or over-reporting, response negativity. The items on the MACI-II require a grade 4 reading level. This is reduced from a grade 6 reading level on the MACI and increases accessibility to the inventory. The MACI-II offers simplified narrative report content that uses contemporary language. The results are integrated with therapeutic practice, linked to personalized treatment, and incorporate recent advances in treatment approaches. A new option for the narrative report is to present scale scores using scale abbreviations, which allows clinicians to provide detailed feedback utilizing the report's profile graph while mitigating concerns about potentially misinterpreting labels. Clinicians can also generate a report with gender-neutral language. The MACI-II provides a full normative update based on a clinical sample of 1,143 adolescents, more closely representing the current clinical adolescent population. It also provides combined gender norms for 2 age bands, 13 to 15 years and 16 through 18 years. This allows for distinctions between younger and older adolescents. A new feature of the MACI-II is a digital end-to-end workflow with the introduction of a digital manual option via Q Global, Pearson's web-based scoring and reporting platform. The MACI-II is available in English and Spanish, and almost all examinees can complete the inventory in 25 minutes or less. An audio administration option is available in English and Spanish as well. The on-screen administration feature for Spanish is available on Q Global and Q Local to allow assessment of clients who are primarily Spanish-speaking. The MACI-II can be administered and scored digitally via Q Global, Pearson's secure online scoring and reporting platform. It can also be administered on Q Local, Pearson's secure desktop scoring and reporting platform. Paper test booklet and answer sheets can also be used for administration. These can be scored on Q Global, Q Local, by hand using the tables in the manual, or by mailing the completed last page of the test booklet and answer sheet to Pearson. Digital scoring is required to generate a profile report or an interpretive report. Like its predecessors, the MACI-II uses actuarial base rate data. The MACI-II produces scores that reflect the underlying prevalence rate of a pattern or condition in a clinical population. Normative data are provided for 2 age bands, ages 13 through 15 and ages 16 through 18, to allow distinctions between younger and older adolescents. In addition to base rate scores, percentile scores were developed for each scale. One of the features that distinguishes the MACI-II from other adolescent personality measures is its theoretical anchoring. The MACI-II personality pattern scales were developed based on Dr. Millon's evolutionary theory, and each pattern is described in terms of its clinical features along 4 functional and 4 structural domains of personality. Millon's personality theory, first described in 1969, is founded on 3 polarities: pleasure-pain, active-passive, and self-other. From this perspective, personality patterns are viewed as learned strategies to secure positive reinforcement and minimize punishment. The pleasure-pain polarity represents the nature of the responses elicited from others, which could be positive, pleasure, attention, praise, safety, or negative, pain, frustration, disapproval, stress. The active-passive polarity represents the behavior employed to maximize rewards and minimize pain. Active personalities typically take the initiative and interact with their environment to achieve gratification and avoid distress. Passive personalities are much more reserved and maintain a more accommodating stance to what their environment offers them. The self-other polarity represents the source to which the individual turns to enhance his or her life and gain satisfaction, or to avoid psychological pain and discomfort. In Millon's theory, the polarities are combined to derive each personality pattern. Additionally, the polarities outline the central underlying and reciprocally reinforcing dynamics of each pattern. The majority of the personality patterns correspond to many of the personality disorders included in the DSM-5. The 11 personality pattern scales do not represent personality disorders per se, because personality disturbances among adolescents may be attributable to their attempts to adjust to and negotiate the numerous internal and external challenges that they face. Adolescent personalities are still developing and are more malleable than adult personalities. 4 core personality patterns are identified by the theory as interpersonally imbalanced. These are the submissive, dramatizing, egotistic, and unruly scales. For these personality patterns, the primary polarity of interest is the self-other polarity, in which there is a strong emphasis on one source of reinforcement at the expense of the other. In the dependent orientation, submissive and dramatizing, adolescents demonstrate pathology through a coping strategy that is unbalanced in terms of its excessive orientation toward others. In the independent orientation, egotistic and unruly, adolescents demonstrate pathology through a coping strategy that is unbalanced in terms of its excessive orientation toward themselves. 4 other personality patterns are identified as intrapsychically conflicted, which speaks to a conflict within at least one of the polarities. These are the conforming, discontented, aggrieved, and forceful scales. The detached personality patterns, introversive and inhibited, turn neither to themselves nor to others for positive reinforcement. A more severe personality variant, measured by the borderline tendency scale, is outlined within the Millon model. In preteens and adolescents, this unstable style represents a mild to moderate variant along the borderline personality spectrum, or a potential precursor to the more severe variant. Millon's theory posits that there are 8 clinical domains through which each personality pattern is expressed. Each of the personality pattern's scales has 3 corresponding facet scales that represent aspects of the primary personality patterns, drawn from the structural and functional domains. The Grossman facet scales provide information on the most prominent domains for each personality pattern. For each personality pattern, the 3 domains measured by the Grossman facet scales are shown in bold in this table. For example, the most salient characteristics of the egotistic personality pattern are exploitive interpersonal conduct, expansive cognitive style, and admirable self-image. The Grossman facet scales were updated for the MACI-II based on identification of the 3 domains for each personality pattern that fit the theory best, and on a rational examination of the item composition of each scale. Possibly the greatest benefit that the facet scales provide clinicians is the ability to deduce theoretically substantiated, clinically sound case conceptualizations, treatment plans, and therapeutic directions. The last component of Millon's clinical personology model relates to interventions. The MACI-II facilitates the treatment process by identifying the most prominent personality patterns and providing insights into how these patterns are conceptualized, how they may have developed, what the most prominent features are, and how they are self-sustaining. We will be providing more information about the MACI-II during webinar presentations. Please check our website for information on the MACI-II, including upcoming webinars. You can also contact Pearson Customer Service at 1-800-627-7271 in the U.S. and at 866-335-8418 in Canada.